Hey guys, and today we're going to discuss the issue of anorexia nervosa and how to treat it. Now, I want to say that obviously this is a psychology video, and not all of you like the psychology videos, so there will be more tech videos coming soon. I'm gonna shoot some more tech videos in the upcoming days, so bear with that. I also want to say that the next precursor I always put in on a psychology video is that it's for the A-level psychology OCR specification, but this isn't. This is just something I've looked into from my own interest, because I'm very interested in eating disorders, and I wanted to talk about it because the findings of this particular study are a bit troubling to me. So I wanted to talk about it. First, let's talk about what anorexia nervosa is. A lot of people know it's an eating disorder, but what are the criteria for diagnosis? Well, version 4 of the DSM, the Diagnostic and Statistical Manual for Mental Disorders, what clinical psychologists use to diagnose disorders in a clinical setting, has 4 criteria for someone to be diagnosed with anorexia nervosa. First one is refusal to maintain body weight at an appropriate level for the person's height and weight, and that's usually defined as 85% of what would be expected for the height and weight. So if they've got less than 85% of the expected level, then they've satisfied criteria 1. Criteria 2 is a fear of becoming overweight even though underweight. So we'll just discuss criteria 1, they're underweight, but criteria 2 is a fear of becoming overweight even though they're under. Criteria 3 is sort of related to that, and from a psychological point of view, it's the most interesting. Criteria 3 is a disturbance in body image, where the person's weight plays too big of a role in self-evaluation, and it reduces their self-esteem, and they put too much of an emphasis on it when they're evaluating themselves. And criteria 4 is specific to women, because some research has shown that anorexia nervosa is not 90% of the diagnoses are given to women. So criteria 4 is specific to women. It's missed three consecutive menstrual cycles, and that's they have to be you have to be put on hormones to have them restarted again. So we've got 4 criteria in there. Refusal to maintain body weight at an acceptable level for the person's height and the person's the person's rate of growth. Criterion 2 is a fear of gaining weight or becoming a fat even though they're underweight. Criteria 3 is a general distortion in body image, where weight plays too big of a role in self-evaluation. And criterion 4 is absence of three consecutive menstrual cycles. So that's what anorexia nervosa is, or at least that's how one credible clinical manual chooses to categorize it. Now that we know what it is, we can start to embed it, or at least have an idea of how to treat it. So we're going to talk about the use of cognitive behavioural therapy in treating anorexia nervosa, and the essence of cognitive behavioural therapy is changing a person's behaviour by looking at the distortions in their thinking patterns that cause that behaviour, and try and getting them to correct those thinking patterns. So this study was by Pike and colleagues, published in 2003, and their aim was to provide what they believe is the first empirical research into the efficacy of cognitive behavioural therapy to treat anorexia nervosa, and they compared it with nutritional counselling, which doesn't really examine a person's thought processes. It's just a psychoeducational treatment that basically the therapist will help them to organise balanced meal planning and do that. So they're comparing CBT with nutritional counselling. Who are the participants? Well, they're 33 women from the between the ages of 19 and 40. This treatment is after hospitalization, so that they're people that have resolved all their clinical symptoms that required them to be in hospital. So they're all patients that undertook hospitalization treatment at the New York State Psychiatric Institute. So you've got some sampling bias there. They're all from the same place, so might be some issues there. How did they pick the participants? Well, the participants had to satisfy 3 criteria. They had to be in commuting distance of the hospital. They had to in their clinical treatment, they had to have and resolved any acute medical symptoms, and they had to normalise their eating at least to a certain level. 43 people were originally asked. Now I'm going to have to look this up. 43 people were originally asked. So of those 10 people, four were referred to long-term day treatment programs. So that's inpatient and outpatient, and the other 6 returned to post-hospitalization therapies. All the patients had to have successfully completed the inpatient treatment, which was defined as 90% of the ideal body weight for their height on the 1959 Metropolitan Life Insurance tables, and these are essentially tables that give heights for men and women, and according to your according to the frame size of your body, it gives an idea of what your weight should be. So they'd all achieved 90% of their ideal body weight. That was that was completion of the inpatient treatment. So we know who they were, they know who the participants were. What did they do? Well, all the research was approved by the New York State Psychiatric Institute Independent Review Board. All the participants were. The study was explained to them. They were asked for informed consent, and so that's all good. But both therapies took the form of 50 weekly sessions with the therapist over the course of a 1 year period after hospitalization. The goals of that care were maintenance of the clinical improvements achieved on the inpatient unit and sort of preventing relapse, which preventing relapse is a big thing we'll talk about later, because it looks like, just from this piece of research, a big problem with anorexia nervosa. The nutritional counselling was chosen because, other than CBT, it's a big it's one of the other big treatments for anorexia nervosa. So that was chosen as sort of the control condition. We've got an independent measure design with 18 of the 33 women have receiving the CBT, and we've got the other 15 receiving nutritional counselling. They all have 50 sessions weekly and beginning the week after hospitalization. On the first session, patients were given a self-report measure asking about how effective they thought the treatment would be, and that was used in the results. If they left the program for any reason, a record was kept of when they left. So, who did the treatment? Because if you know anything about CBT, you know that a big barrier in CBT is whether the patient and the therapist have a good relationship. So it was carried out by 4 experienced clinical doctorate level practitioners. So these presumably people that have a lot of experience and are quite good at it. It doesn't give any detail on who they are beyond that. So obviously we can't make any judgments about how well they're connected with the patients, but they're certainly experienced. The sessions were also audio taped and reviewed by independent researchers to make sure the treatment was being delivered properly. So what were the results? Well, the group receiving nutritional counselling relapsed, so that man went back into anorexia significantly earlier than the group receiving CBT. So 22% relapsed and in the CBT group, as compared to 53%, over half, in the nutritional counselling group. I mean, obviously you've got any problems you ever have with an independent measure design experiment, participant variables and that, but 53% relapse for the nutritional counselling group. That's pretty that's pretty bad. That would suggest that at least that version of nutritional counselling didn't work for those people. In it might be trying to be an objective experiment, but you've got to sort of think that if you think when you're doing a piece of research that you're giving some people a lesser treatment and 53% of them relapse at some stage, then you've got there's got to be some ethical problems there, hasn't there? So for relapse, we've got 53% for the CBT group. 53% for the nutritional counselling group and 22% for the CBT group. We've got the overall dropout rate. So that's not just dropping out. That's dropping out and failure was 73% for the nutritional counselling group. So 73% of the nutritional counselling group failed the treatment for some reason. They either dropped out or failed the treatment. So we've got 73 versus 22 in the CBT group. So it's certainly better at reducing relapse and keeping people on the program. But this is the real kicker. Obviously, the objective of all is to improve people's lives. You can't. There's no point having them on a program if it doesn't help them. So the criteria for good outcome, which was sort of a change in their thought patterns, and obviously reduction of all their clinical symptoms, was only achieved by 4% of the nutritional counselling group. But even still, it was only achieved by 44% of the CBT group. So although it was significantly better in CBT, obviously still less than half the people who were in that research in the CBT group achieved the criteria for good outcome after 1 year of treatment. So you've got to sort of ask yourself why that is, and why is it so difficult to treat. Unsurprisingly, they came up with the conclusion that CBT was more effective at the nutritional counselling at treating people and preventing relapse. So it suggests that it does work better than nutritional counselling, and obviously, like they said, their aim was to provide the first empirical research. So we can say from that it does appear to work better than nutritional counselling, but still, it's not very impressive. If even in the experimental group, only 44% of people are achieving a good outcome after 1 year of treatment sessions. So let's talk about some evaluation issues, shall we? Well, it's independent measures experiments, so that could mean in theory, all the people in the CBT group could just be more have a higher rate of self-efficacy, be more wanting to be better than the non-CBT groups. So that could be a factor, other than whether it's CBT or non-CBT. It could be that the nutritional counselling, the therapists are just worse at delivering nutritional counselling than they are at delivering CBT, which is another confounding variable that could have affected it. I'd argue that there's also some ethics problems there. They as consent. But if you're going to give somebody treatment and it's that bad as the nutritional counselling was, then I'd argue that if you know it's going to be that bad, but you're still giving it to them, there's some ethics problems there. The participants they've all recently been hospitalised, so that could have affected the results. And they all come from America, so they all come from the New York State Psychiatric Institute. So the experiences that they'd picked up there could have made them different from other people suffering anorexia nervosa. So we might not be able to generalise the sample. Anyway, guys, that was that was Pike and colleagues 2003 cognitive behavioural therapy as a treatment in the post-hospitalisation of anorexia nervosa. I really want to hear your comments on this one, because those statistics for good outcome are really troubling for me. Even in the good group, only 44% of people achieve the criteria for good outcome. So what do you think about that? If you can shed any light on other treatments for anorexia nervosa, I'd love to hear about it. Eating disorders is no on the spec, it's just a personal interest of mine, so I'd be really interested to hear what you have to say. Anyway, guys, my website address is down below. This has been Pike et al. 2003. Visit my website if you want more, subscribe for more videos, and I'll see you in the next video. Bye bye.